All right. Well, good afternoon, everyone. Uh, we're going to get started. My name is Vincent Atchity. I'm the president and CEO of Mental Health Colorado and director of the Equitas Project and our Care Not Cuffs work to disentangle mental health and criminal justice. And as it happens, what only could happen in the age of Zoom is, and it's snowing here in Colorado, so I'm stuck in the car rather than back at my desk as I hope to be by now, but I will be there again in a few more minutes. But fortunately, thanks to the technology, we can get going. So just a few words about our summit, which starts today and continues for 2 more Fridays after this at exactly the same time. Our interest as mental health advocates is very much in the extent to which we have depended nationally in the absence of a really meaningful system of care for people that is preventative and reliant upon early intervention as early as childhood, is that we tend to neglect our mental health needs until they reach a crisis point, and at which point the crisis calls for crisis intervention, which very often leads people on a pathway into the justice system, which is not where, as advocates, we would ideally like to see people headed. And what we've noticed is that we've got a lot of partners and allies who understand this better even than we do and are dedicated to trying to redirect people who really need healthcare more than they need to be incarcerated away from the justice system of incarceration and into care that is supportive of better outcomes for them and for their communities. Over the past years, we've convened people at state and national levels, both focused on regions and also on areas of operation. And I've heard a lot from really big cities and efforts made in those contexts to do diversion work, and have observed that our rural partners have felt a little bit left out because the circumstances and resources and needs are so very different in our rural frontier and frontier communities around the country. So we're really excited to have this first summit wholly focused on rural and frontier partners, and have lined up a fantastic bunch of panelists to share their work with you today and over the next couple of weeks. Let me just acknowledge our partners at the Law Enforcement Assisted Diversion Support Bureau, who've been super helpful in working with us to identify great panelists and presenters. I also want to acknowledge support from the David and Laura Mirage Foundation, which has been indispensable to the work we've been doing to promote Care Not Cuffs, or disentangle mental health and criminal justice. I want to thank my staff here, Adam Goss and Emma Troughton, who've been invaluable in putting this series together. And with that, I'm going to introduce today's presenters. The hope is that they will present their work, and then there'll be some time for questions and discussion at the end of the session. So first, I'll just introduce folks, and so we've got Carrie Deacon with us, who's the program director of the Center for Restorative Programs in the San Luis Valley here in Colorado. Heather Brooks, the city manager of Alamosa, also in the San Luis Valley in Colorado. Kenna Gonzalez, who's a probation officer with the 12th Judicial District Office of Probation. Gail Garcia Coons, who's intensive specialized case manager for the Center for Restorative Programs in the Valley. And I believe we're also expecting Chief Dale Meeks, who's the chief of police and in the city of Center, Colorado, and Dr. James Eli Walker, who's an emergency and addiction medicine physician in Del Norte. So with that, Carrie, I will turn it over to you, and I'm going to go off screen and finish driving back to the office and listen to you as I go, and look forward to questions and answers toward the end. Thank you so much for being with us.
Thank you, Vincent. I appreciate it. And thank you for having us here today. I'm going to share my screen with our slides. Can everyone see that okay? Perfect. All right. I'm actually going to hand it off to Heather Brooks. She's going to start us off with the presentation.
Thank you, Carrie. We wanted to share how LEAD even began for us here in Alamosa and the San Luis Valley. For us, it began in 2017 when our council members attended a Colorado Municipal League conference. They went to a session where the state reviewed this program and that the state was going to be providing support to help some pilot cities start it. They left that and asked staff to research what LEAD meant, and what we quickly discovered is that LEAD originated in Seattle in 2011, and the map that Carrie has just put up shows that since 2011, LEAD has quickly spread to other areas across the nation and other communities. The point of LEAD is recognizing that there are individuals who are having repeated interactions with law enforcement, and those interactions are most likely driven by underlying causes such as addiction. From our perspective, we saw it as another tool for our officers. Some of the comments we heard are, we can't arrest ourselves out of this being the opioid epidemic. Another comment is the 14th ticket really going to make a difference? LEAD, as you know, is based on a harm reduction philosophy. And what it means is that instead of issuing that 14th ticket, the officer has the discretion to set it aside, and the participant is turned over with a warm handoff to a case manager who will then work with them to provide wraparound support. Following our research, we partnered with the Alamosa County to issue a request for proposals on selecting a community partner to help be a provider for this. We selected Center for Restorative Programs, also known as CRP. And then we brought together a meeting that included the Sheriff's Office, the City Police Department, County and City Administrative Leadership, the CRP, Public Defender's Office, and of course, the District Attorney's Office. And it's through this group's work that we submitted a grant application to the Colorado Department of Human Services Office of Behavioral Health. We submitted a grant and it was obviously successful, and we received approximately $1.3 million that funded 100% of the expenses. Now, that sounds like a very large number, but I want to point out that it was a big grant because while we were starting it in Alamosa, the intent was to extend it into the entire San Luis Valley. And so I think we'll put up a map here that shows exactly where the San Luis Valley is. So you see Colorado, and then the valley is in south central Colorado with Alamosa there starred. It's a fairly large area. It's larger than the state of Massachusetts, but for that size, we still only have 46,000 residents. So that highlights just how rural our community is. It incorporates 6 remote rural frontier counties. We are also surrounded by mountain ranges, and the impact that has on our service provision can create some challenges. And then we also have a high poverty rate with 3 out of our 6 counties identified as persistent poverty. So for us, receiving this grant was critical because we don't have a lot of resources and we can't always try something new and risk our resources on something that's unknown. So the grant is honestly what made it possible for us to try LEAD in our community. What's very positive is through the outcomes that Colorado has seen through its pilot communities, they have changed it from a pilot program to where it's written in legislatively and can receive regular funding. That doesn't mean we might always receive funding, but it does mean that LEAD in the state of Colorado will be supported. Now, when the city was looking at it, there's several reasons why. The first one was jail costs. We were struggling with officer resources getting stretched in a lot of different directions. We were struggling with the opioid and other substance use issues and recidivism. And we knew that we needed to try looking at something differently to get at those underlying issues, i.e. issuing that 14th ticket just wasn't doing anything. So when we started rolling this program out, we heard from the community that kind of narrowed it down to 2 potential concerns that it's important to share on the front end. The first is some had concerns that, is this a duplication of resources? Are we just creating another social service entity? And the answer to that is a resounding no. This is not duplication. The intent of LEAD is to connect these individuals with resources that already exist in order to help them break the cycle. The second concern is this concept of accountability. If you do the crime, you should do the time. But the problem with that is if you're not getting at the underlying issues, they're going to keep doing the crime. There's going to be more victims. And so that's why we wanted to look at something different. Once we received the grant, we pulled even more partners to the table. We looked at medical providers, substance abuse services, probation, mental health professionals, and homeless housing organizations. And they are regular participants on our policy committee. Now, we have been really lucky that from all these community partners, we have a lot of buy-in, and that is honestly what has helped our program. The other thing that I think being a small community is actually in our benefit compared to a larger metro area is that when we have these community partners at the table, a lot of times it's the CEO or it's the actual decision maker, which is important because when we're talking about barriers or changes that need to happen to the system, it's critical to have the people who can make that change be a part of the conversation. So our program actually began in April of 2018. Now, from a sustainability perspective, if the grant were to go away, we would have to scale back to looking at, okay, what can we pay for just the city of Alamosa? We would probably need 2 FTEs with a budget of about $200,000. Now that, from a frame of reference, we're a city just shy of 10,000, but we are the hub in the valley for shopping, which also means we are sometimes the hub for theft. So if that helps the community out there know kind of from a cost perspective, some relevance, I wanted to provide that. The last thing I wanted to talk about is over the last 5 years, as a city, we've been going through a lot of changes on what we are involved in from a discussion perspective. 5 years ago, we were focused on what a lot of communities, especially rural communities, are focused on: police, fire, streets, water, parks and recreation. But what we've seen is more and more we're getting to the table on talking about issues like homelessness, housing, early childhood care, mental health gaps, substance use disorders, a lot of these gnarly issues that do not have easy answers. When we first began LEAD, the state of Colorado was also rolling out support for co-responder programs. But for us, there is no way we could tackle 2 new programs and be successful. So we've rolled LEAD out. We feel like we've got our feet under us for that program. And so the city is actually this week doing interviews to begin our co-responder program. And that has been possible for us to take a look at, one, because of the success of LEAD, but also because of the ARPA funding. And with that, I'm going to turn it over to Carrie.
Thank you, Heather. So I'm going to talk about the program overview for what we've been able to do here in the San Luis Valley and with our work with the LEAD program. And as Heather noted, we started our programming in April of 2018. What they did prior to us actually starting the program in 2018, also some of this pre-work that our community did with what Heather was talking about, bringing our partners together, really discussing what they wanted this programming to look like for our community here. And so one thing I appreciated about that was once I was hired to run the program was a lot of that had been done. And so my ability to hop in and have that support in the very beginning, I was lucky enough to have that for our community. And so as we noted, we started with law enforcement assisted diversion in 2018 as one of the pilot programs for OBH in Colorado. And as we got started, because a lot of the pre-work that did happen, we were able to roll out our referral process for our partners with law enforcement fairly quickly. In fact, we received our first referral from our police department in May. And so that's a quick turnaround from starting a program to actually receiving referrals. And at the time, we were receiving all of our referrals from law enforcement, and we could get them through 2 different pathways for our law enforcement assisted diversion program. The first was a diversion referral pathway. And this pathway, this is where the officer has discretion at the point of contact if there's charges to decide to divert them at that point to our program to receive the support and resources versus giving them, as Heather alluded to, the 14th ticket or putting them back into the system. And so at that point, it's officer discretion. They make that decision at that point and they make the referral to our program. If officers are coming into contact with people and don't necessarily have a charge or have to arrest them at the point, they also had the opportunity to do social referrals. So those are the two different pathways for our law enforcement assisted diversion program for officers to utilize as a resource for them when they're working in the community and came across a population that were struggling. As we started rolling out this referral pathway and this program, we started noticing that there were some gaps in our community, and there were people who were in our community who were still struggling and didn't necessarily have contact with law enforcement. And one thing I will note, as a rural community, we're very visible in our community. Our officers are very visible, our case managers are very visible, and oftentimes the people that our officers are coming in contact, our communities are very familiar with them. And so how it looked in the perspective of the community and how law enforcement were approaching our participants, it looks different. People's assumptions around what that could look like varied. And so one thing we noticed is people were feeling uncomfortable about having to contact a law enforcement officer just to receive help. And so bringing that back to our policy group that Heather mentioned as well, being able to talk about what that meant for our community, how that was becoming a barrier for some of our community members here in the San Luis Valley. And so with that, at the time, the COSAP federal grant came out. And so with the support of the city and talking with our leadership group, we decided to go ahead and write for the COSAP grant. And mind you, this is in the midst of around 2020. So we submitted the grant and we were kind of in a holding pattern because then we were hit with COVID. And so everything kind of got hit on a pause and was put on hold. And so we're in this limbo area of wondering if we're going to get the funding or not. In the meantime, the National Support Bureau also heard this being a challenge for other communities that were implementing LEAD in their areas as well. So one thing that they ended up doing through the National Support Bureau was adding additional pathway for LEAD. And through this pathway, it's let everyone advance with dignity. So us, again, as a community, decided to implement that pathway for our LEAD program here in the San Luis Valley. So once we started rolling out our community pathway for LEAD, we decided as a community, once again, that we just wanted to open this up to our community partners. So we didn't want to open it up to everybody in our community just making referrals to our program, because we also had to think about capacity for our case managers and their caseloads. So we decided just to roll it out to our community partners. In the meantime, we did hear back from the federal grant and we were awarded the funding through the COSAP grant. So we had to reevaluate how we wanted to manage that pathway for our program. And so this is really where we reached out to our healthcare providers and other healthcare partners with MAT, medical assisted treatments, to figure out ways that we could receive referrals from our partners in those sectors. And so implementing all of those pathways, as you can see through our timeline here, are additional ways we were able to add on other ways for our program to receive referrals. But without the work that we did in the very beginning with LEAD, I don't know if this would have been possible. It was a new way of really introducing this way of thinking for all of our partners, our community, even our participants that we're working with. And so us being able to start here in our San Luis Valley with law enforcement and assisted diversion really opened up the opportunities for us to be able to touch more people in our community. I will emphasize, however, that although we've been able to open up the pathways, our LEAD, law enforcement assisted diversion pathway, still is a strong pathway, and working with our law enforcement is something that's very important to us because they oftentimes still are the gatekeepers for the population that we do serve, which is the low-level offenders. And so talking about that, when our group came together to figure out what our criteria and what our community was comfortable with, that was another pre-work the group did prior to my coming on board. So our group came together and wrote our inclusionary, disclusionary criteria for our program and what our community was comfortable with. Over time, I will say that our stakeholders have also been open to discussing the criteria, and we've had some flexibility in our criteria over time. And it's just something, again, that we've been able to do through the work that we've done with our programming and working with our partners. I will also emphasize the collaborative work with this program. We are dependent on the collaboration. Without the collaboration, we would not be able to do the kind of work that we do with our programming. So it's really important that our partners, our community, our participants that we serve, our focus is really trying to meet them where they're at. And when I say that, I mean for everyone, our communities, our partners, our participants, again, because we do work on a harm reduction model. And so making sure we're also working with our communities to keep them in the loop of what's been going on with our program. So we're oftentimes going out doing presentations. We give updates to city council meetings, county commissioner meetings. We also have, as we've mentioned, our key stakeholder policy committee. And that's the group that have all of our leaders, and I am very fortunate to have decision makers part of that group, and we meet bi-monthly. And this is where we address our barriers, challenges, we give program updates. So it's our opportunity to collaborate and talk about anything that our partners can do to help us with the barriers and challenges in the community. We also have our operational work group meeting, which is our bi-weekly meetings that we hold with our law enforcement partners. And this is essentially the same type of meeting as we come together with our law enforcement. We give updates about our participants, the referrals, and any challenges and barriers with that. Again, this is a new collective system of response. It's very person-centered, and we meet everyone where they are. And then we're trying to facilitate the shift to using public health strategies for public health problems such as trauma-informed engagement, the harm reduction I just mentioned, and sustaining relationships. We also try to weave in, and this is another thing that we're able to do with Center for Restorative Programs, is weaving in the restorative justice perspective when working with this population. Again, the population we serve comes from a community where they burn bridges, whether it's within their own personal circle with their family and friends, or community members where they come from. And so trying to work with them to repairing those harms is part of the work that our case managers do. And the population we serve is adults, so it's 18 and over. And as Heather mentioned, we service the entire San Luis Valley. And so when we say we service the whole entire San Luis Valley, the state of the size, over the size of Massachusetts, and Alamosa being the hub of a lot of our services and resources, transportation becomes a barrier. And so one thing we were doing as a program is providing transportation. And then again, once we were hit with COVID and had to go into lockdown, that had a big impact for our program. And so our referrals, we saw a huge drop in our referrals. We weren't able to be available for warm handoffs. That had another big impact on our enrollment for our referrals, but also that continued engagement for our case managers with our participants was a big struggle. I did discuss all of the different pathways. This is a breakdown of where all of our participants come from. So it's just a visual to give you an idea of where a majority of our participants reside. So it's not all just in Alamosa. And again, here's a breakdown of the different pathways where we started with our law enforcement diversion referrals, our social referrals, and then our community pathways with Let Everyone Advance with Dignity, along with our other healthcare providers pathway. And I'm going to hand it off now to Gail, who is our case manager, and she can give you an idea of what our case management work looks like with our program.
Thanks, Carrie. Hi, everyone. So as you know, I'm Gail Garcia-Coons. I am one of the case managers, and I work all over. I'd like to tell you that at the beginning, we try to disperse ourselves between the counties, but I'm everywhere. So I go all over. So I'll be talking to you about the role of case management. And not that it's because it's my job, but I feel like it's one of the most important ones. We are the first person, when any of these referrals come in, is the first person that they see. When it comes to a diversion or a social referral from law enforcement, I can imagine, or you guys can imagine, when they get pulled over or they're getting brought into the police department, they're scared. Typically, they're either using or they're withdrawing or getting ready to hopefully go and get their drugs. And so they're scared. Typically, they really don't know what to do. They explain the program, but can you imagine trying to listen to what this really means and what they're thinking at that moment? So we're really it's that person that we go in, we sit down with them, we talk to them with no questions as far as, do you want to get clean? Do you want this? Do you want that? It's just basically hearing them of what they want. Doing a warm handoff is that sitting with them, no judgment, letting them know kind of what the program entails, telling them that we're going to meet them where they're at. And this means, you know, and they, while they're looking at us, they've got that look on their faces to say, is this really real? Is this program real? Like they're waiting for, you know, what's the string attached? What do I have to do? It just doesn't seem real is what we hear back from our participants. So we do have a huge motto that we go by, and that's do for, do with, cheer on. And when we say that we do for, it means we do a little bit of hand holding. We do, that's what's so unique about this case management, because you hear case management in several other places, and we are different. We are hands-on with them. We are picking them up, taking them to their appointments, getting them to their court, getting them to see their parole or their probation officers. They're asking us to go with them because they're either scared or they really don't know how to, you know, their communication skills aren't very good. We want to have them feel empowered by, they just need support. As you all know, they probably, well, and they know that they've kind of broken a lot of their bridges. They've burnt their bridges with family. They've burnt their bridges with a lot of people, you know, anywhere from friends to their clergy at the church and things like that because of their use. And so they don't have a lot of people to support them. And so when we say that we're going to be there regardless, with no judgment and helping them through this process, they just really can't believe it until we do it. And so there we go. We talk about the do for. We do with when we say that we're going to go with them to their doctor's office. We're going to go with them to talk to their doctor so that they can look at the abscess that they have on their arms, and they're scared to go in because they've gone in before, they've been judged, they've been looked at and just known as, oh, they're just a drug user. We are there to help them gain skills to be able to talk about what's going on in their lives and, you know, feel confidence that with our program that there are a stigma, the stigmatized is starting to go down so that, you know, they're with us and we're able to hold their hand with them for a while and do with it. And then we cheer on. We encourage them with the time that we've spent with them to be able to go to their doctor's office by themselves, to be able to go talk to their probation officer, to be able to check themselves in when they have a warrant, to be able to say, you know what, it's going to be hard at the very beginning, but you know what, we'll still see you, we'll still contact with you. And that's one of the really big, nice things about our program is there's not really a graduation with us. You know, they stay with us, we get them stable. And, you know, we always keep that constant and that consistency with them. It's really a lifelong friendship. We've had people that have gone from active to inactive to active to inactive. And just because when they feel like they've gotten to a place that's really stable, things happen. Life happens again. They relapse. And they always know that they can call us to say, hey, we know that there's one place that we can go where we learned from the last time, that our case manager will be there, and we create that lifelong relationship with them. And so when I talk to you about the role of a case manager, it's just really that one-on-one with them. We go by our 10 principles of no shame, no blame. We go with, you know, working with other partners. We are consistent. We stay with them and do with them. So do for, do with, cheer on. We also talk about communication and our ongoing supports with them. There again, I've talked about it. We don't leave them. We stay consistent. We help them navigate the systems that they're in. Anywhere from trying to get their driver's license, trying to get an ID so that they can try to get a social security card because their social security card got stolen while they were at the St. Benedict encampment, and everything's been taken from them. They don't have anything to help them try to get themselves back into the system with Medicaid, because Medicaid requires that you have an ID. And if you want a social security card, you have to have 2 proof of places of residency, all these things that typically they only carry in a backpack with themselves. And for our homeless population, it gets stolen on a daily basis. And so really connecting them to resources and helping them navigate through those resources. And then resources are already here. It's resources that have been established in the Valley. And there again, Carrie and both Heather have talked about Alamosa being that hub. And it is. I work from all over the county, but really there's only really one Walmart. And well, there is only one Walmart. And that's really where, if you're going by a financial income that they get. They're on set income. Sometimes they don't even have an income, and food stamps. Trying to shop in, for example, for Costilla County, they have the Family Dollar there, but trying to get groceries is also expensive too. So just trying to help them. We do help with transports, and so that's really huge. And I know Carrie's working really hard to get more vehicles so that we have, 3 or 4 case managers at a time trying to use one vehicle throughout the whole valley, which is really hard. So a lot of communication does have to happen. When we talk about meeting them where they're at, this means, does it meet them under the bridge? Does it us meeting them at St. Benedict at the tent? Is it at the shelter, the local shelter where everybody's at? Is it going and meeting them in their community, meaning, in a house that's, abandoned and doesn't have any kind of heat, and, there's camps all over? Yes, that's what it is. And that's what they really like, is we will meet them where they're at. If they're not ready to quit, and that's the biggest thing at the very beginning, is when we tell them that we're not here to make them quit, it's a plan that we're going to come up with for them rather than us telling them what they're going to be doing. They tell us what they want, and that's huge for them. We talk about a harm reduction model. That is, we introduce them to the needle exchange. And so it just blows their mind that we're taking them to go and get needles so that they can use their heroin or their meth or whatever they're using at the time. And that's hard for them to be able to trust, to say, okay, is there going to be an officer there waiting for me? Like, are you serious? That's how scared they are. And it's just really, that's helping our community as well, so that we are protecting, so that the bad needles aren't in the park, so that children aren't picking them up at the local, there's a park right next, or a preschool that's right next door where a lot of our users will go to use. And so really going and introducing them to the needle exchange so that they can get needles. And eventually we get them to that place, which some of them do and some of them don't, is where they don't want to use anymore. And they're like, okay, what's next? Like, is there treatment? Maybe I could go to treatment, or, we can send them over to the MAP program so that they can start working on Suboxone, Vivitrol, or methadone. We work really closely with Crossroads, getting them in to stay there for 5 days, and then having their mental health treatment on that 5th day that we pick them up to go and get their Vivitrol shot for 7 days of sobriety, which the 2 days of sobriety would have happened, right before they go into Crossroads. We work really close with our, I know Kenna, I've worked very close with. There's even a time where we got to a place where she said she wouldn't put out a warrant unless I was able to get to the participant to get to her by 3 o'clock in the afternoon. I mean, that is huge when it comes to working with our partners and them saying, okay, let's get them in lead, let's get them connected, and let's give them some chances. And so we all know that parole, different entities, all of our partners have different ways of their case management. Sometimes their hands are crossed. Like, I know Kenna has certain obligation that she has to check mark off in order to say that they're successful and with her. But we work with them on the other end, supporting that relationship with their parole and probation officer. And that's what, like I said, talking about how we navigate through those processes and getting their basic needs met. Successes and stories I really like to talk about, just because who doesn't like to talk about how good it feels to have success. Success is also looked at. I remember having a meeting at the with Heather and with all of our community people there, and I did get that question, like, what do you see as success? And it's like, wow, success could be something, that a gentleman didn't, he wasn't on the streets for them to pick up, and he wasn't, he didn't get another charge. It's that he's, working on sobriety, and he's actually in a shelter now, so that he's not on the corner bugging people and committing crime, or out there intoxicated and getting tickets for that. So that's that's a success. The 2 stories that I have is, I have a pregnant girl that I've been working with, and I've been working with a huge part of the population with pregnant girls lately. The San Luis Valley Care Center and Valleywide have been just referring them on over, and it's been a really big success. So we connect them to services. The one girl, she had been in the program for about 3 or 4 months. She was 7 months pregnant, and she knew that she needed to quit in order to have any kind of success to keep her baby. And so slowly I started to, build that trust with her and let her know that I was going to be consistent with her. And she asked one day, like, what does it look like for me to go to treatment? And I said, there's so much help out there for pregnant girls. I'm pretty sure you won't have, there's no bed date, because that's that's a barrier that we deal with, is bed dates and the waiting lists. And so I made my calls over to several treatment centers in Denver. One of them being what used to be called the Safe Haven and now is called Women's Resource Reflection Center, Reflections for Women, sorry. And so that is a 90-day program. And she said she wanted to do it for the sake of keeping this baby. And so we got her ready. I went and picked her up. We came back to our office. They called her. She did the interview over the phone. I was able to send over her, we helped her get a birth certificate and things that she didn't have that we did need for her to go to treatment. We took pictures. I scanned an email to the case manager, and because of course she didn't have any kind of computer or anything. So we scheduled MedRide, and MedRide was going to pick her up on a Tuesday afternoon. And when I was getting her, she needed things like shampoo and things that didn't have alcohol in it. And that was hard because I didn't even know what you could get without alcohol in it, which is a lot of beauty care that we use as women. So we went and we did that, and I could just tell she was really slow, just coming up with things to do just out of the ordinary. And I was like, we just don't have the time to do it. She had to be at the local grocery store where MedRide agreed to pick her up, and it had to be by 1 o'clock, and we're looking at 12:40, and she still needs to go pick up her things. I transported her over to get her things, and I'm waiting in the car, and I'm not in the probably not in the greatest place of it where she was getting her things. So I sat in the car and waited, and it's already past 1 o'clock. So I called the MedRide and said, hey, we're running late. Made all the arrangements that way, and she just was not coming out. So at this point, where I talked to you guys about being really different with case management, I got out of the car and I went to the door. I knocked on the door. They opened the door. I walked in and I asked where she was at. They said she was in the back room. I went to the back room with no permission, and she was sitting on the bed crying. She was scared. I said, hey, we can do this, and gave her all the up talk I could give her with the amount of time that we had. I said, okay, we're leaving. I grabbed her stuff. I put it in the car. I put her in the car, and we left. And I put her into the MedRide, and I followed the MedRide car out of Alamosa just to be sure that they wouldn't turn around. And she's off. She is now getting ready to have her baby. She is sober. She is clean. She sounds amazing. I've sent her a couple of books on codependency and things like that. And the relationship, she's just so thankful. And so to me, that's success. The fact that she even got in the car, and she's going to be able to have this baby and have a few months of being clean is huge. So the last one, but not least, is another participant, another female I worked with. She kept on getting DURs, which is driving under revocations. And she had to get to work in order to pay her bill for probation. And so it's just kind of a catch-22. We don't sit there and tell her that she needs to stop driving. I mean, we encourage her, like, you don't have a license, you're going to keep on getting tickets. Well, she got the tickets, but she would not go to court. She had warrants out for her, and I don't know how many failure to appear she had. So I sat down and I talked to her about it, and there was so much more than what I saw as her just being non-compliant. Like, why don't you just do it? But we talked, and I told her that I would go with her to court. And long story short, we finally got her to the door, and I remember her looking at me and saying, she caught my hand, and I said, we can do this together. And, I get emotional about it because it was just such a huge success for me. We made it into court, and she got to see the judge, and we went on from there. And so success, she made it to court. And that's what I have for you guys. And I think Carrie is going to be back up again, correct, Carrie?
Actually, we're handing it off to Chief Meeks. But thank you, Gail.
Yes.
So I'm gonna go now, right? Can everybody hear me?
You're good. We can
All
hear
right.
you.
Okay. So
Thank you.
hey, welcome, ladies and gentlemen. I'm going to shift gears for you a little bit. I love these ladies. They really make my job easy. They really do. But I want to get into why from a law enforcement stance. This isn't just a feel-good program. I'm sure y'all are feeling really good about it right now, but it's an effectual program. It really has an effect on the streets. I got involved with LEAD when I was in Santa Fe. I was the lead officer on a special enforcement team, which is a community impact team. We were formed because we had a challenge. Our property crime was out of control and it was being driven by narcotics and narcotics use. Property crime, drug crime, you're talking about two sides of the same coin. So what we did is this program had come into Santa Fe. As we started our operations into car thefts and burglaries and rampant shopliftings, what we looked at was that discretionary measure, the ability to take some of this, I like to call it low-hanging fruit, your low-level violators. And instead of making these arrests and putting them into the criminal justice system, and I mean, yeah, there's drug court, but drug court was not being very successful. So we took this program, started linking up with case managers, and with that very specific, intense focus that these case managers give to these people, it was breaking a lot of our folks away from narcotics use. It's easy to see. If you have someone who shoplifts on a regular basis because they need that $40 BB of heroin and they can't hold down a job to pay for that BB of heroin, $40 per BB adds up quick. How many shopliftings do you deter? I think when I left, our success rate or was right around that 40% mark. If we could get someone actively engaged with the case manager, that person fell off the map. We did not see them. I started that program in 2017 with the impact team. Fast forward to 2019, I become chief of police in Center, Colorado. It's a small community, about 2,400 permanent residents, but we have the schools. We have an industrial center for all the farms right here in the center of the San Luis Valley. What I immediately found was the same problems here that we had in Santa Fe. And those problems were property crime being driven by drug use and drug crime. We obviously could attack the property crime pretty easily when it comes to burglaries, car thefts, that sort of thing. But what's unique about rural enforcement, the smaller communities, Santa Fe, about 75,000, Center, we'll be generous, we'll say 2,500. All the officers in Center, all 8 of my officers know all my violators. They know who they are. They're here every day. So our law enforcement assisted diversion, waiting for them to engage in criminal acts, was actually overridden by our social referrals. We know who needs the help. So we started taking those people and engaging with them actively. Hey, I got a program. I can get you the help you need. All you have to do is meet with one of these caseworkers. They will come here to me. They will come here to you. That's all it is. You're not going to see me very much unless you have a backslide, but you're not going to see me once you engage with them. It's not my program. It is yours. We started getting people involved. Once again, our diversions are very low, but our social referrals are very high. It's wonderful. I won't lie. It's wonderful to be able to, COVID aside, to get on a phone, call a caseworker, have them meet you. And it doesn't have to be at the police department. It could be at a church, a park. Have them meet with a person who needs help in person. Sit down face to face and let them take it over from there. Let them start getting them the resources they need. And it's been very effectual. I personally have done 7 referrals for the town of Center. Out of those 7 referrals, 2 of the 7 actively engaged with the caseworker. Those 2, I have literally not seen since. I pass them in traffic and they're waving at me. That's my contact with them. The other ones, we haven't given up on them. As they commit criminal acts, as long as we're not getting those acts of violence, we turn right around and we give them the referral again. Hey, we can get you help. You let me know when you need it. But those 2 out of the 7, you think 2 out of 7, that's not quite 50%, but that's nearly 50% of the people that I don't have to worry about anymore. Even if it's 1 in 3, even if it's at 1 in 10, I'm cutting the cases we're referring to the courts, and a lot of the problems that come with the courts and having to pay fines and have to pay restitution and continuing that spiral. It's challenging. It's my passion that drives the program. I am the leader of this agency. The officers that work for me have developed that passion because they've seen the success that I brought with my referrals. So they do their referrals, and it just becomes a continuous cycle. But you have to have that passion for it. You have to have those people that go out there and actively engage. And I'm not saying every officer has to do it. Not every officer is going to believe in it, but if you can get even 50% of your department engaging these people, especially at the rural level, you will fix a lot of problems. And my favorite success story, we had a young man who was in adult education, 18-year-old. He started off with alcoholism, and his alcoholism was a coping mechanism. And he had started to engage in some of the hardcore drugs. He admitted that he'd used heroin. He had tried meth. He's going to school for a trade. So he's trying to do the right thing, but alcoholism's killing him. We went over for the second time because of COVID, was grabbing hand cleaner and drinking as much hand cleaner as he could over the course of the day, poisoning himself. After our second engagement with him, we got him tied into lead. He started being just managed by that caseworker, daily involvement with him. And literally, I have not seen him since. I see his car, I pass him in traffic. He adamantly waves, I wave back, and that's my extent with him. Folks, if you can't hear it, I'm very passionate about it because it works. Drug court is a mandatory thing. When they fail, they fail. You have to restart it all over again. LEAD is that program that even if they fail, even if they have that embarrassment, caseworkers stay on them. Caseworkers bring them back into it, and we get that success. So I'm available if anybody has any questions, but that is my part of this.
Thank you, Chief. We'll hand it off now to Dr. Walker.
Hi, I'm Ely Walker. I'm an emergency medicine and addiction medicine physician here in the San Luis Valley. And as you've heard from Chief and the rest of the crew, the CRP intensive case management started with law enforcement assisted diversion. I think that program has been wildly successful here in the San Luis Valley. And I think the people who run it quickly realized, why should you have to commit a crime to get enrolled in the program? And that's where we opened this up to healthcare. Within healthcare, you learn about the social determinants of health, housing, joblessness, family situations, transportation, all these things that go into the larger picture of health, and particularly in this case, addiction. I'll be the first to tell you as an addiction medicine physician that medication is not the answer. Oftentimes, it's these larger social determinants of health that really do cause people to get stuck in these cycles and kind of be on the hamster wheel and not be able to get out. Certainly medication does have a role to play in many instances, but it's not the silver bullet and certainly not the overall solution. So partnering with CRP for the intensive case management services has been very successful for patients that I have treated both in the emergency department and the addiction medicine clinic. I think what makes CRP different, within healthcare, we try to address the social determinants of health, but we are truly bound by the walls of the hospital or by the walls of the clinic, and CRP is not. So as you've heard, they will go to someone's house, they'll meet them at their job, they'll pick them up at the homeless shelter, wherever that patient is, whatever the need is. They have the ability to go into the community and address it. And that is a very unique thing. And it's a very powerful thing to be able to do that. And so I think just a bit limitless in that way, and their ability to impact the community and patients in that way. Whether it's connection with transportation to medical appointments, closing the loop on psychiatric referrals, getting them to their medication-assisted treatment appointments, all those types of things can be very impactful for this population. When I think about what has been really great for me, both working in the emergency department, where you see people at their worst. Okay, so you see people come in completely intoxicated, unable to communicate, or overdoses of heroin, those types of things. And you catch them in that moment, of course, when they sober up and are able to have that conversation and talk to them about someone who actually has the ability to not only, love them, but really help them address the shortfallings in their life. Is this a transportation problem? Is this persistent joblessness? Is this housing insecurity? Is it social issues with their spouse? And just talking to them and figuring out what those needs are. One of the neat partnerships that we've developed with our hospital is those case managers will actually come to the ER and do intakes right then and there. Okay, and so this person, again, that idea of a warm handoff, that's incredibly powerful. We've also developed an embedded case manager through partnerships with CRP for my addiction medicine clinic. And so I have one of their case managers, again, right there in my office. And when we identify needs for patients who, needs that I'm unable to meet as a healthcare provider, we can bring that case manager right into the office and, again, introduce them, that relationship. So much of this continuity that's so important for this population. We in addiction medicine have a very much taken a harm reduction approach, which you've heard a bit about. And just to put that into words for me, I think it's to say that for better or worse, we acknowledge that addiction is a part of our community and a part of patients' lives. And we don't condone it, but we acknowledge that we should try to reduce the harms of it until someone is ready to enter recovery and move on from it. And CRP also has a very similar philosophy in trying to reduce the harms of addiction until someone is ready to fully seek treatment and try for recovery. I can tell you one anecdotal story of a gentleman who would come into our ER probably 4 times a week on average, and he struggled with alcohol use, and he would generally come in intoxicated. When CRP opened up their community referrals, he was like the first guy that I referred. And after the referral, so prior to the referral, there was one period I actually saw him in the ER 3 times in 24 hours. And each time he was more intoxicated than when he left the previous time. After the referral to CRP, I literally never saw him again. And I had to call the case manager about 2 weeks later and said, is this guy still alive? Like, did he die? And they're like, no, he's doing well. Like, he's there for his family. He's kind of interacting again. And so, again, that's an anecdotal story, but I think whatever it was that CRP was able to address in this gentleman's life, it was very powerful, and something that healthcare is really not empowered to do. So that's it for me. I'm going to turn it over to Kenna with probations.
Hi, I am Kenna Gonzalez with probation. I serve the 12th Judicial District. We serve the population that's post-conviction, or those that have already been charged. That covers 6 counties and over 820 people, or nearing that. We're very assessment driven, and I will discuss my role in that, what my caseload looks like, the benefits of that, challenges within our rural community with mental health, and how the 12th is addressing that. Obviously, you're going to hear a lot of intertwining between lead and medical services. When I say we're assessment driven, people come in and fill out assessments. We discuss with them. We build some type of rapport and collaboration with other partners to develop a good understanding of treatment matching, what services they need, and would benefit their success. The idea is to promote success on probation, reduce recidivism, prevent being re-victimized or having more victims, and then community reparation. So that's our goal. And during that time, through assessments, we do all kinds of referrals. These referrals include for transportation, which we use Valley-wide Ride here, takes them to grocery stores, laundromats, etc. We use LEAD to help support case management. We have up to 7 different outpatient services. We do medical to SLV MAT, which they also help develop the medical appointments as well. All those things are to hopefully collaborate and work together to make sure that our clients are successful. I do take my role pretty serious. Obviously, we have a heavy influence on the success rate. Probation officers alone, if it's changed multiple times, it's shown to impact success rates up to 58% per client, which means that these relationships that they develop with lead caseworkers, with us, are impactful and they do mean something. So that's the role we have here. My caseload, to give you an idea of our mental health and what we're dealing with, I have over 17 probationers currently right now with significant mental health diagnosis out of 48, which is 35% of my caseload. This incorporates schizophrenia, bipolar, major depression. It's a 50-50 split between males and females on my caseload, and the same split for mental health diagnosis. Additionally, out of these 17 mental health probationers, over 10 reported at the time, at one time in their life, they've attempted to commit suicide. And 5 of these 10 have been recently admitted into the ER or went into doctor's appointments for a pretty severe episode, overdose, or something correlated to their mental health. Severe medical issues is not uncommon on my caseload either. We have untreated diabetes, liver cirrhosis, and terminal illnesses. I have more than 12 currently that are either on disability or applying for it, which is 25% of my caseload. So that's, I think, another point established here with the mental health and medical needs of my specific caseload is that also the females are way more likely to be unemployed. And in fact, that out of the 24 females that I have, only 5 are employed. Additionally, 3 of those are on minimal supervision or is not on the caseload that you would see with the mental health or the significant needs. Obviously, this wasn't improved through our COVID times. Some of the benefits of my job in this rural community and the collaboration piece is we all do work closely together. We know each other, first name basis, easy contact. Most of the professionals here have each other's cell phones, and we're serving the community we live in. In Denver, you might not live in Denver. You could live outside of the community, but all of us here live here, and we have a personal investment in our client success and wanting to see better in our community. So I think that's a benefit here. Additionally, all the families in the community is well aware of the people that are on probation or involved in these programs, and then they have usually a direct line to report problems to us or things that they need. Most of my mental health clients, I know when they're having an episode because family feels comfortable reaching out and talking to us about those things and calling and saying what they're dealing with and the struggles that they have. I do think all of those are a big benefit in this. Some of the challenges I've had in this rural community is that Alamos and the 5 surrounding counties do have access to inpatient programs. However, through the inpatient programs, they're finding employment, housing, basic survival needs while they're inpatient is absent. Most of those things we don't even have, like housing, and the programs are so overwhelmed, there is no way we would be able to establish that by the time they have graduated inpatient, meaning that the clients are going right back to the environment they started with. Additionally, the lead and probation and other services have minimal access to these clients while they're in the inpatient services, especially if they go out of county, making it even more difficult to establish aftercare or any other transitional services. The mental health population in general is mainly dependent on what they've self-reported to medical professionals or mental health professionals, I should say. And as I've been told, they're when somebody is suffering or currently actively in an episode, they're poor historians about their past. There is no dual diagnosis program in the Valley. And additionally, the ones that are in Pueblo are only 4 weeks long. And again, they're not working with local providers. So we have minimal contact with them and availability for transitioning back to Alamosa and that continuing support. In Alamosa, if they're too unstable with their diagnosis or haven't yet been diagnosed, if they haven't yet been diagnosed, they can't get into the dual diagnosis, but they also can't get into regular substance abuse inpatient programs because they don't accept that instability. Additionally, most of our mental health fall between the gap of not being severe enough to be hospitalized in the state hospital, but not being minimal enough. Not having such a minimal effects or disruption factors that they can go to groups and peer support groups, etc. Additionally, the funding here is challenging because in the Valley, we don't have, the detox is only operating on weekends. So if you're talking about dual diagnosis, it's really hard to have any stabilizing places. ADC and IRT could do misdemeanor community corrections for the treatment, dual diagnosis, and the structure there, but we have no funding for those type of offenses to have that environment. Also, because there's not a place to stabilize this means probation officers have two choices: to rely heavily on things like LEAD to help us assist them get into treatment and get into appointments and remind them and track them down. Or if they're so much of a threat and hospitals can't keep them and there's nowhere for them to go, they have to go to jail because that's the only way we can keep them safe and others safe until they're stabilized. So with this, just because I see this more with my mental health population, the severe medical component, because it's been so heavily ignored, they're also not accepted into your general inpatient programs because they don't have the staff and the funds to deal with somebody with such a severe medical issues. And your nursing home and rehabilitation centers won't accept them because they have usually a dual diagnosis issue with substances, and they don't accept, most of them don't accept Suboxone or methadone also in those treatment facilities. So that tends to be a major issue. I can say what the 12th has really done to address these things is the probation officers are collaborating and being creative problem solving with partners, including LEAD, specifically like what Gail was saying. We'll establish connection with them while our clients are in jail to make an aftercare, which will come to my office, have transportation set up to go to their MAT appointment, then maybe go to Gail for a bike, for food services, for clothing services, and all together it's providing more stability. So probation is working to work in collaboration with a lot of these providers. Additionally, we have started a lot of peer support groups, such as female peer support group. These support groups do a lot of creative things, like they've developed t-shirts to show support for others, and it's t-shirts they develop and they put symbolism in them, and they meet weekly. It's to say, I've been there, I've got to this point, you can too, type of encouragement to other probationers. We've also developed an art board and administrative review team that reviews all complaints before they're filed that are not at an immediate risk or have absconded, that we can figure out innovative or creative problem-solving solutions. So what I might have not have thought of, somebody else could have, to prevent somebody from having to go back to jail. What else can we do is basically the bottom line. We have definitely worked to develop more innovation to prevent people from having to go to jail or to be convicted of a crime, and seeing what we can do to successfully get them through. However, mental health is one of our main frustrations and concerns as far as getting the help we need or the assistance we need in the Valley. So I we still feel that pain, and we're working alongside everyone else to do our best to address those needs. And I will give that to you, Carrie.
Thank you, Kenna. There was a question that came up earlier about us working with peer support services. And so I think one of the things that you might have heard of through some of the other partners when they were talking about is a recovery community here in the San Luis Valley. And I feel like that's one area of focus that a lot of our groups have started trying to develop here in the San Luis Valley, because that's something that's lacking, our peer support services for those that we're working with. And so I know the state of Colorado is also working on developing peer support programs here in Colorado. And so to go more directly towards what my program or my role is as a program director is really, so I oversee all the case managers. So I supervise and work with them directly as part of my team and helping them with their caseloads, managing those. I receive all the referrals for screening into the program. I think one thing we have noticed is just because there is a lack of resources here in our San Luis Valley for those that are struggling with substance use and mental health disorders is our inability to have effective resources. And so also managing expectations around those that are referred to our program. As you've also heard some of our other speakers state to the fact that this is not a silver bullet. And although we've had some successes with our program, and a lot of that I also contribute to our relationships with our partners, because without those relationships, we wouldn't be able to do this work that we do so effectively. So without them, we couldn't do that and have these success stories that we're talking about now. However, also the fact that we also are not magic workers. We don't carry a magic wand in our pocket, and we don't magically heal everyone, and recovery is not a straight road. So our participants, they're still human, and they're still going to make mistakes, and they're still going to stumble and fall. And one of the things I love about the LEAD program and how they developed this was the ability for people to still be part of our program as long as they feel the need to. The one thing we hear back consistently in the work that we've done from our participants is the fact that that is one consistent, stable relationship. They developed a trusted relationship with our case managers. So once they do feel like they've deemed themselves as failing, and I say air quotes as failing, then they feel they can reach out to our case managers and re-engage with them to start getting them back on the path again. So understanding that for our participants as well. Also recognizing that arrest, prosecution, and conviction can cause harm and interfere with lasting behavioral health change. And that the cycle of arrest and incarceration further destabilize individuals, our families, and our communities. And so recognizing that the using of the judicial system as we have as a response to behavioral health illnesses and substance use disorders just overwhelm our law enforcement officers and their resources and our healthcare providers as well. And so again, engaging in this type of programming, this type of support that we're offering through our intensive case management services is a new way of doing things. And we do try very hard in our program not to duplicate services, because the other thing we don't want to do is overwhelm our participants we're working with the same thing that they might be doing with another partner. So we work closely with our partners, once again, to also establish how we are different from what they might have internally for navigators, other care coordinators, or case management services that they have in-house with our partners. And again, it's just an enhancement to what they might be doing. So our ability for our case managers to have the flexibility to be out in the community is very unique, but it's also something that we can do as again, as part of the partnership with our partners in our community. So they may have in-house case managers, however, they're the experts in their organization. And so our case managers rely on them and their expertise for their organizational expertise for who they can connect within their departments and the resources they have internally for our case managers to refer our participants that they're working with to. The other thing that part of my job is also evaluation data. As OBH rolled out this pilot program, we did work with the University of Colorado in Denver to produce an evaluation for all LEAD pilot sites. And we are actually getting ready, or we are ending that evaluation now here at the end of June. I also work with our policy team, our operational work group teams. The other unique thing about my position is the ability for us to be able to expand what we've done in the San Luis Valley is the fact that I work with multiple municipalities. So I don't work with just one jurisdiction, I work with multiple. I work with multiple community partners. I work with multiple communities in general. As you As we mentioned, as you can see in our slide here, we cover the 6 valleys. And then again, I just wanted to share some of our statistics that we've been able to accomplish since we started our program. So with our referrals, we're seeing majority of more than half of our participants that are referred come to us and are homeless. And as most areas, not just rural communities, but all communities throughout the nation, I think are all struggling with affordable housing, access to affordable housing. So there's one area where our case managers are constantly having to be creative on supporting our participants with. And then also this referral, so 60%, 62% that are enrolled into our program, that enrollment really relates to the fact that once they're referred to our program and we do a warm handoff, we have 14 working days to get somebody fully enrolled into our program. Essentially what that means is we've met with them, they signed our consent and our ROI form. And we also use the GAIN assessment for everybody who's entering into our program. So once they've completed that assessment with our case managers, then they develop that plan that Gail was talking about, and it's person-centered. So it's a goal and plan that they develop to meet their needs at that time when they're working at them. So once they're fully enrolled, it's also managing the caseloads with the case managers. And so being realistic about how we gauge that for them. And so we have a active status list that we go off of, and we revise that weekly with their caseloads. And so we try to maintain our case managers' caseloads anywhere from 12, no more than 15. And this is mostly because of how far they have to travel to meet with our participants in the community. We also are actively engaging with our partners on a regular, consistent basis. The other nice thing that we have available to us and make it nice for being a smaller community is the ability to train all of our officers. So all of the law enforcement departments that we currently work with, all of their officers are trained in our program and how to make referrals to our program. It's not just one special unit. It's just not one captain over a specific unit that we work with. It's the entire department that we work with. And I also have the luxury of being able to have direct contact with the chiefs in each of these departments. And again, some of the other unique things about this, again, being small, as Heather mentioned in the very beginning, is being able to have those decision makers at the table when we meet and talk about the barriers and challenges that we have here in the Valley. The other nice thing that is unique to us in the Valley is we have access to a police academy here in the San Luis Valley. And so we're also actively working on ways that maybe we can connect with them to train officers as they're being trained through the academy. So just another perk that we have to us here in the San Luis Valley. And then, of course, maintaining our capacity. As you heard Dr. Walker speak to the fact that once people find out what we can do, everybody's excited about that. They see the impacts it can have for those that they're serving. And so being able to also maintain a good caseload for our case managers so they can be effective with the caseloads that they do have. And so those are just a little bit of some of the stuff that I do. I also work with our state partners at OBH and other partners here in Colorado. So one other thing I like to make reference to is because with the funding that we received, as you heard Heather state, is it was a significant amount of money, but not all of that goes to, just, my position or the case managers. It also helps us with client costs for living expenses, medical expenses, transportation, getting them equipment for them to go to school or obtain housing or jobs. And so I think another misconception is that we're just here financially to pay for things for our participants. We are a bridge and connection for our participants to resources in our communities. And that's really where we try to, direct all of those that we are working with to, is to be able to utilize the resources they have access to in their communities for sustainability for them and their lives. That's just as important. And developing those skills and learning how to access those is also part of the work that our case managers do. But and looking at our resource or our data when we were pulling this together is, the financial assistance that we have provided, it's only 39% of those that we provided assistance to. And a majority of that is also going towards some form of housing. Again, trying to find sustainable housing, accessible housing for our participants is a challenge, but another chunk of that is also what Gail spoke to as far as inpatient treatment. And so some places don't necessarily take Medicaid or insurance. And so we've had to pay for some of our participants to actually enroll into treatment, and those can be costly. And then this is just a breakdown of our referrals. And again, I just wanted to make note that we started in 2018. You saw we got going, and then this big drop here in 2020. And again, that impact when COVID hit had a significant impact for us with our referrals and our ability to work with our participants. And then again, just working on the greater good of our program and maintaining our relationships with our partners. And again, I want to thank my partners who joined us today for the presentation. Thank them all for their time and ability to be here, and for their support too, because again, without them, we couldn't do what we do. And I will hand it back to Vincent if there's any other questions.
Yeah, thank you all so much. What a great presentation. And I'm going to check the Q&A section for additional questions. Starting off, I just wanted to, I've spent some time in the San Luis Valley. I really appreciated the contextualization at the very beginning. And you didn't mention what a beautiful place it is, but that comparison to the size of the state of Massachusetts and the observation that you serve the entire valley, I was wondering if you could say a little bit more about the barriers that presents for you and the work that you do.
Okay, sure. So I think one story I share often is, I know transportation is a theme that comes up quite frequently for rural communities. I will also say that our partners have worked significantly on trying to produce additional supports and resources when it comes to transportation. I think you heard Kenna speak to some of those as far as like the taxi services. MedRide is another one that we utilize. And those are helpful for us for medical appointments. Valley-wide is another partner of us who have also agreed to bring on transportation supports to the Valley, and they can help with some of those social determinants as far as like going to the grocery store, going to a laundromat. And then again, for us as a program, being able to provide transportation is something that we saw as a need. And so for us to be able to do that, again, as much of an area we serve, I think it's really helpful to also understand, because of the size that we serve, I can say that with my case managers, if they have a participant they're working with in San Luis, one of my case managers could be out an entire day with one participant working with them to pick them up, bring them, like we said, to Alamosa where Walmart is, to do grocery shopping, to do wash their clothes, to go to medical appointments, and then working with our partners to get their appointments on the same day that our case manager can bring that participant to the area, so they're not having to make multiple trips. So it's a lot of collaboration and coordination with our partners. And again, the importance of communication is another area our collaboration has had to be creative with how we communicate with each other. Because again, as we brought on our healthcare providers, like with Dr. Walker, we really had to think about, the HIPAA and being, the confidentiality that comes with that, and how we can, again, share information, data, things like that with our healthcare providers. And for me, I know for us to do that, it's really been the conversations and relationships that I've been able to develop with our partners to do that with and have those conversations. And Heather, I don't know if there's anything you wanted to add to that.
No, it's a long drive when we start going out to the other communities, and so it does take up a lot of the case manager's time.
Carrie, can I add to that?
Yes.
I was just going to say that one of the barriers I'm sure that you guys deal with, that we deal with as well, is the fact that in that whole community, in that area, is also a large immigration population and Spanish speaking population, and people that don't know their access to treatment, or they're farming communities and they don't have, they're isolated, they don't see all of the resources that could be available. And I think that's kind of unique to our area, because a lot of those on my caseload, this goes right into mental health. Their immigration to the US has a lot of traumatizing experience, for one. For two, they don't have Medicaid, they don't qualify for Medicaid, and they don't know of any other services. And additional to that, they can't get legalized work. So they're also being victimized that way as well. So I think that's unique to that population in that rural area.
Thank you. So another question from the Q&A is, what are qualifications for case managers?
So for our case managers, one thing when we're doing hiring for our program is we really want somebody who's had some experience with this population, those with mental health, substance use disorders. I will say we don't require somebody to have a degree to do this work. I'd rather have someone who's had some experience with this population, knows the community, knows the areas. Again, because we rely heavily on the resources here in the San Luis Valley and our collaboration with our partners. I think the other nice, unique thing about a rural community is because we do know one another, as Ken alluded to, is also helping and bringing down some barriers for people who are resistant or maybe hesitant to receiving any outside supports. So again, when we're working with the population and we're coming in and as an outsider, we're trying to build up that trust, and not just with our case managers, but we're also trying to build up the trust with our partners, our healthcare providers, even our probation officers. And one thing I guess I will say too, when we're working with our criminal justice partners in probation, it is not our job to, we cannot be mandated to services. So our program is strictly voluntary. And so that's one thing I forgot to mention is when somebody agrees to work with our program, it has to be a voluntary process. We cannot be mandated to serve as services. We can't be part of conditions for any plans for probation, social services, or the courts. And so again, when we're working with them, and if they are involved in the criminal justice system or probation, it's really our job to make sure that we're breaking down any barriers and challenges to them meeting those needs for probation or the courts or whatever.
Thank you. And another question from the Q&A, how many case managers do you have?
We currently have 5 case managers. I am down 1 case manager. Another challenge, I think, for rural communities, and this might be across the board, but is our workforce. Trying to find people who, one, want to work in this line of work, and then also have qualifications to do this type of work. And so I know for us and our partners too, even Crossroads is one of our detox facilities here in the San Luis Valley. They were open 7 days a week, 24 hours a day, and now they are only available during the weekends right now because of another workforce shortage.
And another question from the Q&A is, given the vastness of the territory, does that present problems with regard to warm handoffs from one service to another?
So I want to say no. So my case managers live throughout the San Luis Valley. So like Gail's in Conejos County, I have a case manager here in Rio Grande. I have one in Alamosa. And so strategically, when I have a partner who has a referral, most of the times I can find a case manager who is available to go meet with our partners to do the warm handoffs. So not yet.
And Carrie, correct me if I'm wrong, because I'm not sure we touched on this, but we are strategically placing the case managers where we officially have expanded lead into. So we couldn't just open it up to all communities right away, because from a capacity learning experience that we couldn't do that. So I don't think we're actually into officially every single city yet in the Valley. Is that correct?
That's correct. So thank you for clarifying, because when we receive referrals, our participants that are referred to us could live anywhere in the San Luis Valley. But those communities, like I think I saw one come up asking about Saguache specifically. And so we do work with the town of Center, which also incorporates part of Saguache County, but we have not expanded that to the entire Saguache County because it is such a big county. And again, right now, capacity wise, we just don't have the capacity to do that.
So when we bring in these new entities, it usually entails not necessarily a one-to-one correlation, but it does entail bringing on another case manager. And so that way it helps. So when we talk about the warm handoff usually occurs because those warm handoffs with the law enforcement is in areas that we have that official relationship with, and we have strategically placed the case manager.
Correct.
Thank you. Another question from the Q&A is, so are all referrals vetted through a single location or person?
Yes. So I receive all referrals right now, and the screener. I will say though, I do have a team that we do staff them with, so it's not just my decision. We also work closely, and I think I forgot to mention this. We do work closely with our district attorney's office, and they are a big partner of ours on our collaborative for a lot of different reasons, resources, collaboration. And again, because we do cover the 6 different counties, it's helpful to have that partnership with them.
And are case managers paid or unpaid?
They are paid.
And that was another question from the Q&A, and another question from the Q&A, and we may have time for one more after that, is just to clarify the source of the grant funding. Was that the Office of Behavioral Health?
For our LEAD program, yes. So for the Law Enforcement Assisted Diversion, Let Everyone Advance with Dignity pathway, the funding does come from the Office of Behavioral Health.
But then we also added on the COSAP grant, which is federal funding.
Correct.
Thank you so much. Do you have any final things you want to say to the group?
I do, and I'm sorry, team. As I was listening to the team talk, I think the other thing that's amazing from a LEAD program is when these people, when they start breaking the cycle and they start repairing those bridges they've burned, from a small rural community, there's just this huge impact. I mean, these are our families in our community that had almost given up on this family member. And so it's healing families and those relationships as well. And so it's more than just transforming the lives of those individuals who are participants. It's transforming the lives of the families too. And I wasn't sure if we put enough emphasis on that, but it really has an impact when you're a small community.
Yeah, thank you so much, Heather. That's a really important point to make about that ecosystem. Anybody else? Final remarks?
Just thank you for the opportunity, Vincent, for us to be able to speak about our program here in the San Luis Valley.
Well, we're super grateful to you. And, as you know, at Mental Health Colorado, we do a lot of our work at the state capitol, working on mental health policy. And, part of our objective in bringing this group together for this summit series is to identify work that still remains to be done at that policy level. And so would really welcome any thoughts that you all may have, if you want to follow up with me and suggestions about that. Once we've had another moment or two to catch our breath from the session, which just ended last week, we will start turning our wheels with regard to what's in store for next year's work. So would love to be able to support you in whatever way possible in that regard. So let me just also, a final thanks to our partners from the San Luis Valley. Thank you all so much for a fantastic presentation. This has been recorded and will remain available on our website for any and everybody. I imagine that you all are willing to be contacted by folks who have heard today's presentation for follow-up questions. Just let us know and we'll put you in touch. Next week will be the second of our summit series, and we will be featuring Bill Thompson, who's a prosecuting attorney in Idaho, and his colleague, and others as well. So it'll be another great presentation, mostly focused on prosecutor-led diversion. Our other partners will be from South Dakota, and their names will be up on our website shortly. Thank you all. Wishing you all a great weekend, and we will wrap promptly here at 3:30 Mountain Time. Happy Friday.
Thank you.